Thanks. Thanks very much, Krish. Fascinating stuff. And yeah, we often talk and think as clinicians in terms of the conditions people already have. So we can try and get a dual effect, a double effect. They've got angina, so you might give them a calcium channel blocker if they've got hypertension, for example. But actually to be thinking about what they may get in the future, I think it's just fascinating. So we're now on to discussions, and I think some oh, okay, I'll just start things going. So, and I'll try and sit down here if this is open. King, yep, great. One of the things, just wanted to introduce Alan. So Alan Griffiths, who's PPI lead for Dynamics RX. I don't want to put you on the spot necessarily, Alan, but if you did want to say something at this point, then I'd be very happy.
Yeah, is this work? Yeah, it's fine, isn't it? I suppose one thing I've been thinking all since this morning, really, about what I might talk about if you were to ask me a question. And I think one of the things, yes, I've got multiple long-term conditions. Yes, I'm taking 14 different drugs. Which is the more important to me? I think it's the fact that I take 14 different drugs and the polypharmacy side of the whole thing. And I don't know if anybody noticed, but I actually took a tablet whilst Lauren was talking, and that was a hydrocortisone tablet, which I should have taken at lunchtime, but I'd completely forgotten to take it. So luckily, I always keep a little tin of the things in my pocket just in case. And if I can just say, go back to that, up to the, by the way, I'm exactly 74 and a half today, so I'm half a year away from being 25% over 50. So, sorry, 50% over 50. If that makes me old, I guess it does. Doesn't it? No. But yeah, I was 59 when all of a sudden, I think I was in a gym and the alarm bells went and the doctor said, you've got hypertension. And whilst doing that, I had something else developed whilst he was working out which drugs to take and so on. And it turned out I also had a pituitary tumor. And the type of pituitary tumor I've got is one that's it's in front of the pituitary gland, and it's hypopituitarism or something. I can't pronounce it, never could. And one of the things that is, it means that my body doesn't produce any cortisol. Cortisol, I think I'm right in saying, is a fight or flight, whatever it is. And 2 weeks after I was diagnosed with that, my wife, my late wife, was diagnosed with terminal cancer. We've a son who has a severe learning disability. So you can imagine, can't you, the stress we were all under at that time. And me not being able to, not having the fight or flight thing meant the stress. I mean, I'm needless to say, I had to give up work and so on. And it was really, really, really difficult for that time. And that, I think, has made me think more about, if you will, that, you know, the polypharmacy side of the whole thing. It's not so much what I have in terms of conditions, it's what I have to do to stay healthy. Does that make sense?
Yeah. And one of my colleagues who's a patient rep very much talks about the patient as project manager, and in a sense, it's a big, if you're on 14 meds, that's a big project. And as you say, remembering critical medicines as well, like your hydrocortisone.
Well, I remember walking down the corridor at the hospital, my doctor, who was I was seeing about the tumor, he said, "Oh, are you remembering to take all your hydrocortisone tablets?" I said, "Yeah, don't worry. Yes, somebody told me that if I didn't, I'd be dead within a month." And he laughed and he said, "Oh, not that long." Needless to say, I didn't laugh.
Great, thank you, Alan. It looks like we've got some questions. Yes.
Hi there. We've been talking a lot this morning about the impact of the wider picture, context, and psychosocial variables. And my question was, with your predictive models, are you factoring in certain demographics that might be more at risk of polypharmacy? Would that kind of flag up on your models? And also, Really interesting to hear what you were saying about the amount of medications you're taking and adherence. Would that be another potential thing that could flag up on the system? Because obviously if patients aren't taking their medication, then they're going to get very poorly, and there might be an increased chance of lack of adherence with more medication. So I wondered if you were considering those types of risk factors and maybe building that into your predictive models.
I think they're sorting it. Yeah.
Is this for me then? Yes, looks like. Okay, and the first thing to say is we are not trying to predict who is going on polypharmacy, but rather saying what works for a particular person who has particular demography and particular health condition and history of certain prescribing. In that, do we take into account of all the demography factors? Yes, but only what is available as coded data at present. It is obvious that very much that if you take any data, additional data, particularly that is documented as text like we heard this morning, and if you can bring in additional data like across in terms of what patients may want to enter, that can help a lot. So sometimes I believe when you start fresh, you can take this thing into consideration when implementing a system. So for example, the project I said in Sri Lanka, there will be a patient-facing app as well, and they can input information as well. So a wider amount of data can be taken into account.
Great, thanks. Mike, did you want to say anything?
Well, I guess what I'd add to that is in terms of prediction, we can only predict with the data that we have, and quite often that kind of data is not available. And I think all we can do is highlight where it is available, where it needs to be collected, and we will often get that from our patient panels. And something else to add to that is, for example, in the case of aging and healthy aging, there's quite often a lot of over medication. So for example, blood pressure is set at certain levels that are considered healthy, but those levels probably aren't appropriate for quite an elderly person that actually may end up being over medicated because blood pressure rises with age. So in that way, it's important to recognize that actually different groups may need different thresholds.
Yeah, thanks. Yep.
Just about your comment about adherence, because I think it's really important. So in terms of prioritizing people for review, there are some of what a lot of our clinicians fed back is that there are people who fit the obvious metrics around, they've got lots of different conditions and they're prescribed many medicines, but then there's lots of people who, because they've got complex lives and difficult lives, are not able to attend appointments or not able to collect their prescriptions, and therefore those are the people that are at risk of lots of conditions but not necessarily engaging with care. And by just using tools to search for patients that are based on the number of prescriptions you have actually might introduce a health inequality, because it might mean that there's lots of people who actually are at greater risk and I always come back to that difference between there are people at risk and there are people who are at the greatest potential for benefit from a review, and they're not necessarily the same people. And actually it makes the job harder, but there are a whole host of people that would benefit the most if we were able to engage them and intervene. So yeah, I take your point entirely.
Great. I think we have a couple of. Yeah.
Hi.
Great.
Hi.
Thank you.
Rashmi Kumar, I'm a patient rep. Thank you very much for this topic, because this is such an interesting topic. And Alan, thank you for sharing your story, because I think you represented real patient there, the kind of challenges that the patient experience. So thank you for sharing that. My question is really about developing a tool like this. Absolutely, it's needed. However, Lucy Chappell talked about this morning about translation and getting that tool out there into the community, that trust being built. There is a workforce issue. Even pharmacists don't understand how the tools work, how the various medications work. GPs don't understand that totally implication of taking one medicine against other. And that communication between the secondary care and the primary care. Very often patients go into the hospital and the consultants in the hospitals are saying, take this medication. We need to change that. Information doesn't get into the GPs, and GPs say, no, 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 there is some confusion here. You've got this issue and that issue. So I think it's important to understand, A, how the tools work. We need to get the training, the communication, the messaging across the profession correct, so everyone understands. And crucially, that level of confidence and trust to the patient. I think, as you mentioned earlier, it's not a question about changing medication. It's informing the patient of why it is necessary to change the medication, how it's going to improve. Otherwise, they will just end up with even more complex conditions into the hospital. So what I wanted to know is, what are your thoughts in making this model translatable, implementable?
Great. Do you want to go back to I think
You go
much
first.
more complete. So any of this work, co-production, should be at the heart of this work. So most of the work is in discussion with our members. And secondly, obviously we rushed through slides, but how would a physician like to view it? Equally, the same information, how would a patient like to view it? So that amount of research has to go in place for it to work. So that's number two. Number three, you pointed out where we are struggling for workforce and so on. How do we manage to do it? And this is extremely important because whatever we produce should reduce time and better care. And that has to be quantified through good qualitative research rather than our type of analysis. So those are very important. And thirdly, how do we actually show that information to patient? Of course, we are working towards that, but more important what you said, is this going to be in practice? And this is the struggle we as researchers at times have, because what we have produced are prototypes. And if this has to come through production line and right there in front of patient care, it means working with industry or creating various other ways of making that work. For example, the one I showed, Medicate, the cardiologist did it himself every day, traveling through to Sheffield, and then wanted to make it for research. He couldn't find funding. Finally, the NHS entrepreneurship enabled him, and now he's produced it as an output that can be used by ICBs, initially as a training tool, and then as an audit tool, and then once it goes through the evaluation and the regulatory process as a decision support tool. So people want to do it, but it will take time.
Thanks. And I agree with all those points. And you very succinctly put together all the barriers that all of the clinicians that I speak to and the patients say the exact same thing, that how are we going to get past the sort of the barrier that is the understandability or explainability of tools? You know, how do you tackle it? You know, if an AI tells you that this person is at risk, how do you even go about understanding where that has come from? Can you rely on it? And I think one of the, you know, I don't have an easy answer, but I think one of the really important things is for us as a community to continue to say that that is a barrier and a challenge that we need to address. Because I've, as you might imagine, as the other hat that I wear is I'm a medicines developer. I test drugs in humans, and there's a tremendous amount of interest in the use of AI for drug discovery, identifying new medicines and things. And I quite often pose this exact same question that you did. How are you going to get past the barrier that is, if you're trying to make a new medicine, but you can't explain to me where, because the black box nature of the AI, where that came from. And it's the exact same problem. And sometimes, and I'm often approached by developers for digital tools like this, where they can't really explain to me why it works or why it's identified certain patients at risk. And I said, but then how am I expected to be able to use that? Because if I don't know where it's come from. So I do think that we have a responsibility to continuously highlight that this is challenging. This is going to be really hard thing, because this is not what I learned at medical school. So there's a steep hill to climb. So.
Yeah, so I can't add a lot to that other than say I think probably the way to translate it is to go for small scale, to look locally, and in our case in East London we collaborate with a community program called East London Genes and Health, and there are links with clinicians that are working with the community, and you can then potentially work with maybe one GP practice to apply maybe a tool that predicts if somebody's got polypharmacy that might exacerbate chronic kidney disease, for example. And then you could just do it working very closely with one clinician or a group of clinicians. And I think that's probably one way to do it. It'd be very hard to, implement something across the whole, trust all in one go, because GPs and patients have a similar level of understanding of AI, and it's a public understanding of AI.
Great, thank you. Okay, is it Bon?
Yeah, I would like to ask something to all of you really, and that's just picking up several points that you've raised. And that is, where do you see this within the pharmaceutical industry? And I'm raising this because, as we all know, most clinical trials are conducted on patients who are fit and healthy, and now we're talking about patients with multiple morbidities, etc., who would be excluded from drug trials normally. I'm interested about the minimal therapeutic dose that we could look at, because actually, whether it's 5 milligrams, 10 milligrams, 20 milligrams, whatever, it's a bit hit and miss, isn't it? Depending on the patient. I'm wondering, how far do you think this could really go, where we could get real personalized medicine into patients at the right dose? Do you think there will be a day that we could use AI in some way to help us do this?
Yeah, I mean, absolutely. I think that as I'm sure we've all said at various points when giving these kinds of talks, is, the data that you get out from any of these tools is only as good as the data that went into it. And our challenge from a drug trials point of view is that all the data, as you say, comes from a very restrictive part of the population. And I say that as somebody who recruits healthy volunteers to trials. The way that we develop the doses in particular, the way that we say a particular dose is safe, is done in very young, very fit people, and that have kind of perfect physiology. And then nothing is done between, then we take that drug to see if it works, and we do multiple stages to see if that drug works, but nothing else is done in terms of the safety of that dose level in people who are 85. So the challenge we've got is that we just don't have that data. We don't have pharmacokinetic data for 85-year-olds taking antihypertensives, because it was never done. So the step that we need to do is to do that bit, because it's not difficult to do. It's not difficult to bring 8 people into a specialized unit, give them commonly used drugs and take samples from them, over the course of a day. It's not burdensome, it's not challenging, but the amount of information that it gives you about whether that is the correct dose, so is the exposure the same in that person versus a 21-year-old male, would be invaluable for the models that very clever people not go on to, the people who know how to develop these methods would use. But that is the problem. If you use the existing data, it wouldn't, all comes from a very an unrepresentative part of the population.
Krish, Mike, Alan, either you want to add to that excellent response? Thanks, Lauren. We've got another question down at the end. Thank you.
Yeah, so as someone, I have a rare disease and I had a 4-year diagnostic odyssey. So I know what it's like to live unmedicated, and I felt tortured by my symptoms until I got that diagnosis and got access to biologics, which changed my life. I suppose my question is there a stigma attached to being labelled as a polypharmacy patient, which I have seen? And actually, should we be changing the language and talking about the right drug for the right patient, and crucially at the right time?
Well, I'd say absolutely. I mean, to be honest, that is what, in my role as National Director of Prescribing, is the sort of mantra that we really try and put across. I think that the challenge is polypharmacy has become an issue because of sometimes the inappropriate or overuse of medicine. Then it's got that label, which I don't think anyone actually really likes. But would anyone else like to comment on that?
I mean, I generally, when I'm speaking to patients, I say many medicines. That's what, that's the phrase I use for patients, is many medicines. But yeah, I guess the word polypharmacy has, I suppose, it's just evolved because that's the kind of research landscape.
Would anyone else like to say anything else on that? Okay. Yep, Alan.
No, I mean, I don't feel any stigma at all, to be perfectly honest.
Yeah.
It's like I said earlier, it's what I have to do.
Yeah.
To stay, you know, and if talking to Lauren, a doctor last week or the week before has decided I need to be on another one, so that'll be 15 as for like next week or whatever, which is only a combination of 32,768, which I'm sure my GP can work out quite simply whether that's all. But no, as I say, I see it as it's my responsibility, if you wish, is to take them.
Yeah. Great. Well, I think that's come to the end of the. Oh, we've got one more quick one. It's this
Typing on Slido at the minute,
it's coming through on Slido.
coming through.
It's sort of working its way through the internet. Apologies, everyone. You're on tenterhooks here. Right.
Tony, will it be okay if we invite him to speak on Zoom, if that's okay?
Yeah,
Take his
yeah,
question?
yeah.
Let me tell him.
Wow. Technology.
Hello, can you hear me?
Yeah, we can hear you.
Right, sorry, I was trying to make sense of what I'm thinking of, and it took some time. I was writing it, but so it's easier to talk about it. So my point is, the AI is very interesting to, yeah, we make all the models and everything, but how many of them are being actually implemented? One main challenge would be around the ethics of that. How would we be able to release some AI models from the data providers? For example, Mike presented a gradient boosting model for kidney issues, and then some explainability tool around for that. But is it possible to release such models from CPRD? I don't know. I haven't used CPRD much. So I don't know whether those models can be actually implemented. What is around the ethics of these? Basically, how AI models can be released from data providers in order to be implemented for supporting doctors and patients in primary care or secondary care or so on.
Great. Okay, thanks. And that's a really, really important point. I think Mike can pick up on that.
Yeah, I mean, I think it's a good point, and it's something that has come to mind for me a lot with things like data sets like CPRD. They are millions of patients, but they are there's a lot of information we don't have, and I think we'll probably be able to use these kind of tools to develop a model that might work. But then before you could implement it in the NHS, you would have to test it on not real patients, because CPRD is real patients, but patients where you have access to a lot more information, much more accurate information, so that you could then show that it actually works in a cohort of patients that are in your clinic rather than just a hypothetical data set.
Great, thanks very much. I wanted to give a bit of a summary, but I think time is up really. Okay, well, I mean, I think it's just been fantastic, really. I mean, as a person who's now in policy, I'm in research, clinical, and in policy. The type of work that you are all doing, including people on the panel, is so valuable. I'm very aware there's talk about, well, only about 5% of predictive models get used. Or the thing is, as you know from all science across history, it requires this effort of multiple people. And sometimes it may be more luck than anything else that it's your particular thing that actually gets through. But I think it's that collective effort. It's the fact that you're doing it in this shared collaborative way that is so important. I really, really do see the value of this for the future. I really do see how it is going to make a difference. It make a big difference that you're doing it in a collaborative way, co-designing with patients and people, members of the public. So I just want to thank you all, and thank you all in the audience here for the great work that you're all doing.